to speak for us today. Dr. John is actually a personal friend of mine. He is a board certified cardiologist. He works for currently working with Advent Health. He is he was educated at my alma mater. I went to Nova Southeastern, and so did Dr. John, but he went to the osteopathic school. So uh, he he's currently working with Advent Health. He's director of their cardiology outpatient services. He's a trained and board certified interventional cardiologist, and I'm sure I could waste another 5 minutes talking about all of his training and education. But I'm sure you'd rather hear some great information on guidelines for the management of heart failure. So, Dr. John, thank you very much for helping us out today. We appreciate it.
Oh, thank you, Mike. Thank you for having me. I appreciate everybody attending today. And today we're going to go over because there's been some recent updates for the management of heart failure and a change in our guidelines for heart failure, and even how we even diagnose heart failure and how we classify it. There's a lot of confusion when we look in our charts and how we classify and call people heart failure. Well, there's a lot of confusion in what we say. We use systolic heart failure, diastolic heart failure. Then we have terminology with heart failure with reduced ejection fraction, preserved ejection fraction. And for many years, we had this gray area of, the heart failure, the heart ejection fraction was greater than 35%, but less than 50%. What do we call those patients? So now we have like a new classification of how we're diagnosing these patients and classifying them. But we still have some hurdles to go over because a lot of the EMRs that we use, and when we're putting stuff into the patient's charts, they don't have some of the newer diagnoses. So we're still forced to choose some of these other terminology with systolic heart failure, diastolic heart failure, if it's acute on chronic, and kind of go from there. But hopefully in the near future, things will be streamlined a little better, and we're all using kind of the same nomenclature. But when we start talking about therapies, for heart failure, any type of therapies that we use in medicine, we try to follow some sort of guidelines. And when you guys take your boards, and we all take our boards, some hot things that they always talk about and things I always want to test on are when you have these classes of indications. And that's what we look at in guidelines. We look at these classes, and we'll either class one, class two, or class three types of recommendations. And this is based on like the strength of the recommendation is this is something we should do or should we not do something? Or our class one recommendations, these are our strong recommendations. These are things that, listen, we should be doing these things. And our class two, that gets broken up into like a 2A to a 2B, where a 2A has some stronger recommendations, some validity to it. 2B, the benefits might outweigh the risks some, but we got to be cautious on some of these. Then we go to our class threes, where these are things we probably should not be doing. We have no evidence of is this beneficial or not. And some of the class threes, it's actually just harmful and it's something we should not do because we can cause harm. So when you guys are taking your boards and kind of getting your recertifications, things are really focused on are the class ones, because they're definitely going to try to test you on your class one indications, but also those class threes, things that we should not be doing. So those are the hot ones to kind of focus on the class one and class three indications. And then these two, when you break up these class two, we really focus on the 2As. They almost never test you on these 2B indications, but so the class one, maybe the 2As in there, but definitely the class threes also. And then when we look at this, we also look at, well, what's the evidence behind it? Is it, a strong evidence? And that goes into like a level A, B, or C, where our level A evidence, these are our double-blinded, randomly controlled trials. We have multiple trials, multiple centers that have been tested to show a benefit. So that's the best kind of evidence that we have, and that correlates sometimes to our class one indications. And then if you go down to a level B or C, where sometimes a level C can be just a consensus statement of clinical experience. So this is what kind of when we come together and we set up our guidelines in our meetings, this is what we're looking at. We're looking at the trials. We're looking at the level of evidence. Is that a class one indication versus a class three indication? And should we be doing it? So as far as our definition of heart failure, we have different ways we do classify heart failure. And there's a classification of stages of heart failure. And there's 4 stages. There's a stage A, B, C, and D, where now we've gone to not just classifying heart failure itself, but people at risk for heart failure. So a stage A is someone that's at risk for heart failure. So they have no symptoms whatsoever of heart failure, and they don't have any structural heart disease or any testable biomarkers that show any cardiovascular disease. But these are patients that have hypertension. These are our diabetic patients. These are patients with metabolic syndrome, obesity, or they have a history of cardiomyopathy, or they tested positive for a gene variant, but they're not showing any signs of heart failure. So again, our stage A, these are people at risk. They don't have heart failure, but the likelihood they have a higher incidence of progressing to heart failure throughout their lifetime. Next is our stage B. Our stage B, these are what we call our pre-heart failure patients. Again, no signs or symptoms of heart failure, but they have some evidence of either some type of structural heart disease or increased filling pressures on some of our imaging or testing, or patients that have risk factors that have some positive biomarkers. So some structural heart disease we're looking at is, do they have decreased ejection fraction of the left ventricle or right ventricle? Do they have LVH? Do we see some of the enlargements of their chambers or their ventricles or their atrium? Do we see wall motion abnormalities on some imaging studies, or do they have valvular heart disease? So if they have some type of structural disease, but not manifesting any symptoms yet, this is our stage B patients. And we can also do some hemodynamic monitoring. We do some right heart casts. We see elevated PA pressures or RV pressures, or on echocardiogram, we can see similar evidence of this. Or we have patients that they have risk factors, they're diabetic. We check a BNP level, it's elevated. So this could be our stage B patient as long as they're not having symptoms. Or if we see elevated troponin levels with no other reason to have troponin elevations. We can see troponin elevations in people that have acute coronary syndrome, if they have chronic kidney disease, a pulmonary embolism, or these myopericarditis patients. But if they have a reason for the troponin elevation, that doesn't count. So we're looking for patients that have risk factors, no other reason to have elevation of these markers. Well, we put these into stage B. The next is our stage C. These are our symptomatic patients. These were the patients that we're treating for heart failure. The majority of the patients are lying in. These are the majority of the patients that are coming to the office with heart failure, and our hospital affiliations are coming in. So stage C, these are our symptomatic heart failure patients. And then our last stage is our stage D. These are our patients with advanced heart failure. We've done goal-directed medical therapy. They're still failing. They have recurrent admissions. They're not getting better. These are the patients that we're referring to our advanced heart failure centers for our advanced therapies. Either it could be LVAD, transplant, or other IV infusions that we're giving these patients. So for today, we're going to focus mainly on the A, B, and C stages, and D we can talk about at another time. So again, our stage A, these are our at-risk heart failure patients. No symptoms, but these are our diabetics, metabolic syndrome patients, maybe a family history, or they have a gene variant for cardiomyopathies. Our stage B, again, are pre-heart failure patients. No symptoms yet, but they have some evidence of disease process going on with some type of structural heart disease or increased like filling pressures on our echoes or right heart caths or some other type of testing. Our stage C, these are patients with symptoms. These are our majority of our heart failure patients. And our stage D patients, these are the ones that, despite all our medical therapy, they're still having recurrent symptoms and need advanced therapies. When we talk about our stages, once you're in a certain stage, you don't leave that stage. You can't go backwards in a stage. Not like our New York heart classifications are 1 through 4, where you're class 1, you don't have any symptoms. Class 2, you have very mild symptoms with activity levels. Stage 3, you have moderate symptoms with your just regular activity levels. In stage 4, you have symptoms at rest. And that's a dynamic evaluation where you can go from one class to another there. When you're talking about your stage A, B, and C, once you're in that stage, you don't go backwards, but you can move forward. And then you can advance that stage D, where you're requiring more advanced therapies. So again, in that class C, you're in that class C. Once you're in that class C, you're pretty much there until you kind of advance to the class D, if you advance. So if you're class C, you can be a kind of a new diagnosis of heart failure. And then you can have resolution of symptoms and improvement of symptoms, but you're still class C. You don't go back down to a class B. Now you can have persistent heart failure symptoms with class C, again, advance to that more concerning class D, requiring more advanced evaluation. Now, another way we classify heart failure, and this is kind of a new change that we've seen with the classification, is classifying heart failure by the left ventricular ejection fraction. So We call a reduced ejection fraction now as anywhere if you have a left ventricular ejection fraction less than or equal to 40%. So that's classified as reduced. And a preserved ejection fraction is a ejection fraction of 50% or more. Okay, so that's preserved. And in the past, we didn't have a gray area. That gray area now we call it mildly reduced. So if you're in this 41% to 49%, we call that heart failure with a mildly reduced ejection fraction. And what we also put a classification is if things improve, if you were in that reduced category, that less than 40%, and then you improved to 40%, then we can call you heart failure with improved ejection fraction. So here's kind of a table that kind of sees the trajectories of that heart failure based on ejection fraction. So if you're initially diagnosed with a heart failure with an EF of less than 40% or equal to 40%, that's at reduced EF. And you can improve. So you can go to heart failure with an improved EF if you get above that 40%. Now, if you're in that mildly reduced category, you can go down, but going up, we're kind of in a gray area here. So we're kind of, at a loss of, do we call you preserved again? We're not going to call you improved because we left that for patients that were less than 40% and then went above 40%. So you're kind of in that gray area if you were kind of mildly reduced and kind of went above 50%. But if you're preserved on your initial evaluation and you're greater than 50%, you can always go down to the reduced or mildly reduced, or you can stay at the preserved level. So when a patient comes to us and we're concerned about heart failure, and we suspect heart failure, there's things that we should do for our initial assessment. The first thing is just doing our history and physical. Do they have signs of volume overload? Do they have JVD? Do they have edema? Do they have hepatic congestion? Are they short of breath? Are they athopnic? We can kind of assess these things and get their history, what their activity is. Are they sleeping on pillows at night? And that's a change. Are they doing less activities because they're more short of breath with just walking? So getting the history and exam are a big portion of the initial evaluation, and also with family history. Next, we're going to get labs, basic EKGs. We're going to rule out any secondary causes that put them at risk for heart failure. Are they diabetic? Do they have high blood pressure? Do they have a family history of it? Are they in atrial fibrillation or any other conduction abnormalities on the EKG with PVCs or things that make them more prone to having conduction abnormalities on the EKG that would put them at risk for heart failure? Other tests we can do is look at the BNP levels. These can be helpful for a couple different reasons. One, someone that comes in with dyspnea, can we rule them out? A BNP, it's a good test. It has a good negative predictive value, meaning that if it's low and negative, we can have a high rate that maybe this is not heart failure. But if it's elevated, there's a lot of things that can cause an elevated BNP, and heart failure being one of them. Next thing is doing an echocardiogram. If we want to try to diagnose them based on their ejection fraction, we need some type of study to look at what the ejection fraction is. And an echocardiogram is a easy test to do, a non-invasive test to do without radiation, without chemicals, to look and assess at the structure of the heart, the valvular structures, the ventricle, and the ejection fraction of the heart. And then we can classify them. Do they have a reduced EF of less than 40% or equal to? Or are they in that mildly reduced category, or are they still preserved with an EF of greater than or equal to 50%? And then once we get this information in, start evaluating and see what factors can make them more prone to going into heart failure, and then start treatment for them. So we talked about what's our indications, our class indications. When we talk about our history and physical exam, it's a class 1 indication that every time we see a patient, get their vital signs, talk to them, assess them for their fluid status. So every visit, we should be getting vitals, assessing their fluid status to see, do we need to make adjustments to diuretic therapies or other medications to help improve their quality of life and maybe morbidity or mortality? Also, we want to see, are they advancing? Are our therapies working? Are they getting better? Or we need to assess them. Do they need advanced heart failure evaluation at one of our tertiary centers to help improve their symptoms? Also, we want to assess if they do have a cardiomyopathy. We want to start going back maybe 3 generations to see, do they have other family members that have a history of a cardiomyopathy, and identify maybe any inherited causes that we need to evaluate for, and maybe send these patients for genetic testing. and then kind of evaluating them for what other behavioral modifications that we can address, lifestyle changes that can help reduce the progression of their disease. I mean, are they drinking too much fluid or taking too much salt intake? Go over their diets and their exercise programs and what they're doing to help reduce the risk of progression of their disease. Now, one big cause of heart failure in the United States is coronary artery disease. So we call it ischemic heart disease if it's affecting the heart function. But there can be non-ischemic causes that we can look for and need to address also if we ruled out that they have any coronary artery disease. As you guys know well, there's certain chemotherapy agents and other cardiotoxic medications that can affect the heart function, along with rheumatologic or autoimmune disorders that can affect the heart function. We're also going to assess for endocrinology, metabolic disorders like pheochromocytoma, diabetes, obesity, or thyroid. All these things should be looked at. Familial causes, hypertension, infiltrative diseases such as amyloid, sarcoid, hemochromatosis. Myocarditis is a hot topic right now in our field with COVID, and COVID having a higher likelihood of causing myopericarditis, along with the vaccinations. And we're seeing this in our patient populations and causing arrhythmias that are leading to symptoms. Also, stress cardiomyopathies and substance abuse that we see. It's an epidemic that we have, especially here in Pinellas and Pasco counties. I don't know where all you guys are from, but and definitely in Florida, in certain areas, we definitely have an epidemic of drug abuse that we're seeing younger patients with cardiomyopathies that need to be treated. So again, with testing, with a lab testing, class 1 indications to do basic testing to look and see what is putting our patients at risk for heart failure. So CBCs, looking at any blood disorders, urinalysis, electrolytes. We're looking at BUN creatinine levels, glucose levels, lipids, liver function, iron studies. Again, we're looking for hemochromatosis, thyroid panels, and trying to optimize these to reduce the risk of progression. Also getting EKGs, just a 12-lead EKG, looking for maybe long QT syndromes or other conduction abnormalities with maybe frequent PVCs or indications, maybe there's some RV dysfunction that can make people more prone for heart failure. Other class 1 indications that we're looking at is looking at BNP levels and using this maybe as a diagnosis of exclusion or maybe to help risk stratify our patients in the office or even in the hospital. In the hospital patients, a lot of times we're using these BNP levels to help establish a prognosis. It's a class 1 indication to help establish prognosis. We know that if they're very elevated, they have a poor prognosis 30 days after hospitalization. So it's kind of important to identify these. Now, as far as following these throughout the hospitalization as a serial marker, that's usually a 2A indication. Not as strong evidence, but we are using it at times to see, do we see a 50% reduction in the BNP levels during the hospitalizations with our treatment to see if that's improving their symptoms, and even at discharge to kind of give us a benchmark of where they're at so we can follow that and see our therapies working, or do we see a regression with our BNP levels. But we got to be careful because there's other things that can elevate our BNP levels. And if anybody's worked in a hospital in any type of clinical setting, we know that our patients, it's not like when you're in school training where they gave you a lot of times one problem to assess on the patient. Our patients come in with multiple problems and it kind of overlaps. And so sometimes it's hard to kind of sift through and see, well, why are the BNP levels elevated? It can definitely be in heart failure or acute coronary syndrome. If they have LVH or valvular heart disease or some type of pericardial disease, rhythm abnormalities can do it along with myocarditis. If they had recent surgery or cardioversion or other type of metabolic disorders that can add insult to the heart. Just being older can have elevated BNP levels. Patients that are anemic or renal failure, high blood pressure, or critically ill septic patients, we see elevations in these. So it can cloud the picture to see, well, maybe I can't rule them out, but let's see what the levels are and see if we have a reduction in these levels during treatment, if that can help guide us in our therapies. As far as genetic testing, it's a class 1 indication for first-degree relatives that have been diagnosed with some type of genetic or inherited cardiomyopathy. And if you have a non-ischemic cardiomyopathy, it's kind of a two-way indication to kind of send these people to, if we don't have a reason why they have a cardiomyopathy, to some type of genetic counselor to start testing them and maybe their family members. But when these patients come in and we're concerned about some type of genetic cardiomyopathy, um, boards love to test these rare type of occurrences. You might never see some of these throughout your lifetime, but you'll definitely get tested them on your boards. So some things that we see is, of course, your hypertrophic cardiomyopathies that you definitely will see, and that's definitely come more to light with our young athletes um, um, having cardiac arrest while playing, especially with Damar Hamlin, seen on football on TV and seen it right in front of us. And in the past, young basketball players suffering from this, and even our young youth athletes that we've had in our local area that have died over the past 10 years with hypertrophic cardiomyopathy. Next is something called an LV non-compaction syndrome. That's something we look out for, or some type of RV fatty infiltration that can happen. So these are all things that are possibilities that should be tested for. If we have unknown reason why, or if we see changes on our echocardiogram or other type of imaging that can lead us to believe that there's a genetic component to their RV failure. Other things that can cause cardiomyopathies are dysrhythmias. If they have non-sustained ventricular tachycardia or frequent PVCs, usually it's a more than 20 to 30% of a burden when we do our Holter monitors. And if we see more than like a 20 to 30% PVC burden or AFib burden, then they can have a higher likelihood of cardiomyopathy. So these patients should definitely be referred to maybe our electrophysiology specialist to talk about maybe ablation therapies or other things that we can do to target these arrhythmias to reduce the risk of progression of heart failure. Also, patients that have early onset of AFib or early onset of conduction diseases needing pacemakers before age 65, they're at a higher risk also. As far as imaging, echocardiogram is an easy way to take a look at someone's ejection fraction to try to classify them. But we also have class 1 indications for getting a chest x-ray. Chest x-rays help us evaluate volume overload. We see those curly B lines and pleural effusions on our chest x-rays to help diagnose and sift through to see what's going on if there's fluid that's built up in the lungs. Also looking for heart size or any other reasons that could have symptoms. Again, the transthoracic echo is helpful, but then there's also other class 1 indications. If the echo, sometimes we can't see the heart very well. We can't assess the heart function very well on a 2D echocardiogram. Well, there can be other modalities that we can use with CMR, with MRI now. That has become the gold standard if you have access to it to assess LV function. And if you don't have access to cardiac MRI, then there's something with our radionucleotide imaging, something called a MUGA scan that we can do that used to be the gold standard above an echocardiogram to assess LV function. And it's still in many of the community centers kind of the best at our fingertips to assess LV function other than cardiac MRI. But cardiac MRI can be very helpful because it can help diagnose infiltrated diseases, look for ischemic causes and viability in our muscles of the cardiac muscle. So very helpful tool that we have now. So some things that we shouldn't be doing when we talk about things that we learn, just evaluating LV function just to do it is something that we kind of is not recommended. But if patients have a change in symptoms and we're concerned about their symptoms, and if it can alter our therapy, then it's recommended to kind of have serial evaluations of their LV function to see how it's going. If we're changing our therapies, and again, if their symptoms are changing, it's just something that should be implemented. But just routine every 3 months or 6 months to look at someone's LV function, that's not the recommendation. As far as an invasive evaluation, sometimes it's tough to assess our patients. Now, sometimes it's hard to tell, are they truly volume overloaded or what's going on? So sometimes we recommend invasive evaluations to look at pressures, or also sometimes we look to see, well, what could be the cause of a cardiomyopathy? If it's an infiltrative disease, is it myocarditis? So it can be useful. And if it will change our therapy, then biopsies, right heart biopsies are a lot of times indicated to evaluate someone's heart failure. We had a patient recently that's come to Advent Hospital um, that was recently sick with the flu, influenza, and had just floored myopericarditis. It was fulminant myopericarditis that we put assist devices in the left ventricle and right ventricle to help support the heart function. We ruled out any coronary disease, and we were able to do biopsies to confirm that it was truly a myopericarditis from an infectious etiology and start treatment right away, and also implore our advanced failure to therapies on them. So it can definitely be helpful in guiding us in our therapies. Again, as far as just doing a biopsy on everyone that walks through the door with that you suspect heart failure, that's not the indication. We do a right heart cath, although it's minimally invasive and you do biopsies, it's still an invasive procedure and there's still a risk to that procedure. So to put everyone through a biopsy, it's not recommended. You have to have some kind of clinical suspicion to do that. Now, as far as this invasive hemodynamic monitoring, putting swans in and doing that, it's a recommendation. It's a class 2A recommendation. If you have a hospitalized patient and not getting better with therapy, difficult to assess them, then we can put a swan in and use a swan on a daily basis to see what their wedge pressures are, the PA pressures are, to see how our therapies, we have them on Lasix strips to see how well they're diuresing, what their volume status is. But again, just to routinely do it, not recommended. This is morely recommended where patients that are failing therapies that we have, and we're trying to do more advanced therapies to try to monitor them. So our stage A, again, the stage A patient, these are our patients that are at risk. So what can we do for our stage A patients? No symptoms, okay? They have a risk factor. Our main things that we're going to do is we're going to look at what their risk factors are. If they have high blood pressure, class 1 indication, we're going to optimally control their blood pressure. So one of the newer kids on the block that are helping us with heart failure are the SGLT2 inhibitors. These are our Jardiance, our Farxiga, and our new one, Ozempica. So if you're a stage A and you have a reason to be on it, right? So no symptoms, but you're diabetic or have a higher risk for cardiovascular disease, it's a class 1 indication to start these SGLT2 inhibitors. If you have cardiovascular disease, we're going to optimally manage that. If it means with medications or any type of invasive treatment or reperfusion or revascularization, we're going to work towards that. And again, if there's any cardiotoxic agents, we want to find out what they are, if they need to be on them, if it's someone with breast cancer or some other cancer that we're treating, that they need some type of agent that can be cardiotoxic. We need to kind of have a team approach to see, okay, if it's starting to affect their heart function, we need to be in communication with each other so we can help each other to kind of adjust our therapies as needed to help with the overall treatment of the patients. Also, if you have a first-degree relative that has a genetic disease that predisposes you for cardiomyopathy, get screened and get counseling for that. Now, as far as these at-risk patients, just testing BNP markers or going to these other risk modules, these are kind of 2A indications, things that we can do, but doesn't have very strong evidence to do it. It's not something we should always do. Now, once they hit stage B, these are patients that are kind of pre-heart failure. So maybe they're not having any symptoms, but their EF is less than 4 or equal to 40%, but no symptoms yet. Well, these patients were usually starting on an ACE inhibitor. Not really starting the ARNIs yet, not really starting Entresto in these patients yet. They don't have any symptoms. So patients without symptoms, but we saw some structural change, it's a class 1 indication for an ACE inhibitor. Now, if they can't tolerate the ACE inhibitor, angioedema, other issues, then we can start thinking about ARBs in these patients. Now, also, if their heart function is less than 40% or equal to 40%, but no symptoms, it's also a class 1 indication for beta blocker therapy. In these patients. So beta blocker therapy, ACE inhibitors, these are kind of our first line treatment for patients that we call pre-heart failure. Now, if we kind of evaluated patients and they come to us and they say, I don't really have any symptoms, but their EF is less than 30% or equal to 30%. And let's say they had an MI and post MI. So past 40 days, they had an event, but now they're not having any symptoms, and their EF is still less than 30%. Then we start thinking about putting implantable devices like defibrillators in. So it's something to consider in these patients. So our stage B, again, we want to prevent progression into our stage C. And what we found is that some of these medicines that we use can actually reduce mortality. Some things that we use, and when we look at our recommendations, we're looking at things ideally that can reduce morbidity and mortality. Now, some medicines we give, they don't do that. They help with symptoms, and that's mainly some of our diuretics that we use. But medicines that can reduce our morbidity, mortality, and hospitalizations, they hold more weight to kind of start initiating for our patients. So again, if you're less than equal to 40%, we should really try to start ACE inhibitors on these stage B patients. If they had a remote history of an MI or some type of acute coronary syndrome, these patients, they should be on statins, right? We should assess them for heart failure symptoms at every visit. Also, if they had a remote history of an MI, but and their EF is less than 40% or equal to 40%, but really no symptoms, we really should have these patients and try to get them on beta blocker therapy to kind of reduce mortality in these patients. Some things that we really shouldn't do, the TZDs, these are some medicines that can cause harm. So we got to be careful. When we start to have patients that have reduced ejection fractions, when they start getting less than 50%, the TZDs, we got to try to avoid these medications. And also your calcium channel blockers. You got to be careful with some of your calcium channel blockers. They have a negative inotropic effect. They can be harmful. So once we start seeing a reduction in the ejection fraction, we want to try to shy away from these medicines, start using beta blocker therapies. If they have a history of coronary artery disease, start putting them on statin therapy and move from there. Now our stage C, these are our symptomatic patients. These are kind of the majority of the patients that you're going to see in the hospitals, treating them with IV therapies. They're coming in very symptomatic. So these patients, they should have this multidisciplinary approach, treating their diabetes, their blood pressure, volume status. We're trying to really reduce the readmissions to the hospital, along with improving their overall survival long-term. So some class 1 indications, again, we want to give education first. Education these patients, identify what their risk factors are. If they're diabetic patients, high blood pressure, they have LVH, counsel them in their diet, lifestyle modifications for these patients. Try to see what the barriers are and try to overcome those barriers to try to improve their long-term symptoms. With heart failure, the sodium restriction is a class 2A indication. So something that shows a benefit to help reduce symptoms. Now, doesn't improve morbidity or mortality, but it reduces congestive symptoms and overall quality of life. As far as exercise, it's a class 1 indication to try to improve functional status. Patients that have higher functional status, exercise, they do better. So we really want to get these patients moving around. Our goal is to have 2 hours and 30 minutes of exercise on a weekly basis of kind of moderate activity. And it can be as easy as just starting a walking program, walking 15 to 20 minutes in the morning and the evening, kind of getting that cumulative effect of at least 30 minutes a day as best as possible, at least 5 to 6 days a week, to try to hit that goal of 2 hours and 30 minutes on a weekly basis to improve their overall function. Patients that do have volume overload, it's a class 1 indication to give diuretics for these patients. Now, again, like I said before, this doesn't improve morbidity and mortality, but it helps with symptoms. It helps improve symptoms, and the patients will definitely greatly appreciate that. And, it's not fun having this extra volume on board, can't move around, uncomfortable, you can't breathe. These patients, we really want to start with like loop diuretics on these patients and see how they do. Try to avoid the TZDs in these patients. If we have to add a thiazide diuretic to them, like metalazone, that's something that can be done only when we kind of maximize our dose of our loop diuretics and try to add then kind of your thiazide diuretics on. So some commonly used diuretics that we use, Bumex and Lasix are probably the most common ones that we use, along with furosemide. There's definitely other diuretics that we use, but IV, Bumex, furosemide are common ones that we use. And as far as maximum doses, we try not to go over 600 milligrams of Lasix or 10 milligrams of Bumex in a hospital or treating these heart failure patients. As far as hydrochlorothiazide and metalazone, metalazone again is probably our next, along with hydrochlorothiazide, common medicines that we use, and sometimes we use them in combination with our heart failure patients. As far as our ARNI medications, that's our Entresto with our ACE inhibitors and ARBs. What we found is that the ARNI, the Entresto medication, gives more benefit than our ACE inhibitors or our ARBs. So it's a class 1 indication if you have a reduced ejection fraction, if you're symptomatic. So that means not a class 1 New York Heart Association, class 2 or more. Okay, class 2 to 3. We recommend the ARNI medication over an ACE or an ARB. Now, if you can't tolerate the Entresto, then the ACE is your next line of treatment. Okay, and if it's a cost benefit ratio, then so be it. Then the guidelines have recognized cost benefit analysis to help with patients. But if they can tolerate the ARNI and they can get the medication, that should be our first line to try to get patients on with a reduced ejection fraction. So again, but if they're intolerant to it, if they're intolerant to ARNIs or they're intolerant to ACEs, then we can go to our ARBs. That's kind of our next class of medication we can use that can reduce morbidity and mortality. Now, if they're on an ACE or an ARB and they're tolerating it and they're class 2 or 3 and they're still symptomatic, we really want to try to transition them to the ARNI medication. So our goal is, if they're tolerating it, to try to get it to added benefit. But again, if there's anything that's precluding them from doing that, then we can stay on the ACE or ARB medication. Now, when we're doing this, though, some class 3 indications, things that we should not be doing, is if you are on an ACE inhibitor, we have to let that wash out of the system before you start the ARNI. So it's got to be 36 hours before you start this medication. Okay. And also, these medications, if they're having a history of angioedema, we really should not be giving these medicines, ARNIs or the ACEs, if they had a history of angioedema with any of these medicines. As far as beta blockers, it's a class 1 indication for patients with reduced ejection fraction, but not any beta blocker. Remember, with our beta blocker therapy, there's only been 3 beta blockers been studied well with reduced ejection fraction. And this is bisoprolol, so that's your Zebeda. This is mainly not as used as commonly in the United States, more in Europe, but definitely there's some patients that will be on this medicine. Some higher use medicines is Coreg or carvedilol, along with our toprol medicines, the long-acting formulation of metoprolol. So these have been shown to reduce mortality and hospitalizations in patients with reduced ejection fraction. As far as our mineralocorticoid receptor antagonists, or MRAs, so this is your eplerenone or spironolactone, your aldosterone. These are recommended in patients, a class 1 indication for these medicines if they have reduced ejection fraction and if they're a class 2 to 4 New York Heart Association. So not if they're asymptomatic. So remember, class 1, no symptoms, but class 2 to 4, these are patients that have either mild or moderate to severe symptoms. As long as their GFR is greater than 30, and their potassium is less than 5, it's a class 1 indication to start them on spironolactone or MRA medication. Some of the new kid on the block, that's this SGLT2I inhibitors. This is our Jardiance, this is our Farxiga, this is our Inpefa medications. So if they have a reduced ejection fraction, it's a class 1 indication to start these medicines, regardless if they're diabetic or not. Now, if they are at stage A in diabetic, it's recommended to start these medicines. But again, once they're symptomatic with reduced ejection fraction, it's a class 1 indication to put this medication on. So this is kind of one of the newer therapies that we're using. Some things you have to watch out for is renal function. If they have severe hepatic disease, you might have to be careful. But with CKD in these patients, as long as their GFR is greater than 25, it's been shown to be safe to give these patients, but it's something you should definitely monitor. Remember, these medicines, they're a mild diuretic. They affect sodium. So um, um, they can reduce the preload along with afterload, so you can get worsening renal function in these patients. Another kind of class of medicines that we use in a certain subset of patients. So hydralazine with isosorbide in our African American patients that have either a class 3 or 4 New York Heart Class Association with reduced ejection fraction have shown to reduce morbidity and mortality in this patient population. So that's something to always consider: hydralazine and isosorbide on top of our other medicines in these patients at not class 2 heart failure, but 3 and 4 New York Heart Class to help with these patients. Now, also, it's a 2B indication to use hydralazine and isosorbide if you can't use ACE inhibitors in these patients. So for whatever reason, if they're intolerant to the medication, so not just our African American subset, but if it's a patient that can't tolerate the ARNI medications, so ACE or ARBs, then we can consider hydralazine with isosorbide to reduce morbidity and mortality with these patients with reduced ejection fraction. So again, so kind of our step treatment for patients in the stage C or D, this reduced ejection fraction. So their ejection fraction is less than or equal to 40%. We want to get these patients, if they're class 2 to 3, we want to get them on that ARNI medication, get them on Entresto. Okay. If they can't tolerate it for whatever reason, then it's reasonable to put them on an ACE or an ARB in these patient population. We also want to get these patients on beta blocker therapy, want to get them on the MRAs, the SGLT2s, and use diuretics as needed to help improve their symptoms. And then we want to reassess their function. You know, if their heart function, if the ejection fraction gets above 40%, then we kind of reclassify them as heart failure with improved ejection fraction, still a stage C, okay? But then we kind of just monitor them on a regular basis with that history, physical exam, how they're tolerating the medications, looking at their vital signs, and continue with that goal-directed medical therapy and continually assess that. Now, if their heart function is not improving, if they have persistent symptoms, then we have to try to look at what other therapies can we add or give to our patients. If it's that African American subset and they're still progressing and they're not New York Heart 3 or 4, that's where we can start adding that hydralazine and nitrates in. If their EF is dropping and it's going less than 35% or equal to 35%, and they have a survival more than a year, then now we're starting to consider ICD therapies, that implantable cardiac defibrillator, to try to improve sudden cardiac death and reduce the risk of sudden cardiac death. If we're following these patients and their EF is low again, less than or equal to 35%, we're getting the EKG. Now they have a left bundle branch block, and that QRS is greater than 150 milliseconds. They might qualify now for what we call resynchronization therapy. So not just a lead in the right ventricle, we can put a left ventricle lead in and do a cardio resynchronization therapy with a defibrillator to try to improve overall heart function and symptoms. If they still progress, these patients, now they're going to our stage D. These patients need to be evaluated in our advanced heart failure tertiary centers for our advanced therapies evaluation for transplant, and from there, or maybe even palliative care, if we're limited on what we can give them. So there's other therapies that really haven't shown much benefit and actually cause harm. So keep in mind, the hot ones are these ones that cause harm. So patients that have a reduced ejection fraction, we should not be giving them calcium channel blockers. Okay, really, and especially the non-dihydropyridine ones. So your verapamil, your diltiazem, it's not recommended. They have a negative inotropic effect that can really put them in worsening heart failure. So you got to be careful with these. So really try to avoid our calcium channel blockers. Other things that patients try are certain vitamin supplements, nutritional supplements, hormonal therapy. We really don't know if there's any benefit to these type of therapies. So these should be used, again, with caution, and really no proven benefit at this time. Other things you got to watch out for, because a lot of these patients, they can have rhythm disturbances. They'll might be on a class 1C antiarrhythmic. They could be on flecainide, or they could be on Moltac. You got to be careful. These patients that come in heart failure, they should be coming off these medicines and looking at other medicines to help improve or treat their arrhythmias. Again, TZDs, We got to find other treatments for diabetes if they're on TZDs and heart failure. It's been known, like especially like Actos, these medications got to be careful with, along with your DPP4 medication. So avoid these medicines in your heart failure patients. Well known too, NSAIDs. These can worsen heart failure, so be careful. It's a class 3 indication to prescribe NSAIDs to a patient with reduced ejection fraction. So common medications that we're talking about, your NSAIDs, of course, your COX-2 inhibitors, the TZDs, be careful with the flecainide, Multac, also your alpha-1 blockers. They can have a moderate to major effect on patients by stimulating the beta-1 receptors. You increase renin and aldosterone in the body, and kind of works against what we're trying to do with reducing fluid retention and preload on these patients. Again, the calcium channel blockers, we can have major adverse effects with a negative inotropic effect on these medications. So really, patients that have heart failure, exacerbations of heart failure, especially with reduced ejection fraction, we need to avoid these medications. Now, as far as treatment, it's been a kind of an initial indication or recommendations that, well, we should get patients on these medications. So now when a patient gets diagnosed with heart failure, right away, they're going to be on 4 medications. And the question is, well, how do I get them on 4 medications and make sure they're tolerating all these medicines? And some of the recommendations is, okay, we'll start a medications and we'll start to up titrate them every 1 to 2 weeks. Now, if we do this one at a time, and you have 4 different medicines, and every 1 to 2 weeks, it might take you 2 to 3 months or longer to get patients on the dose of medicines and all the medicines they need to help. So we're looking at other ways of actually just starting medicines at lower doses altogether, and then up titrating every 1 to 2 weeks and see what they're tolerating. So not just starting one at a time, but get them started on lower doses of all the medicines and then up titrating them to get them on the medicines and get the benefit earlier than over a 3 to 6 month period of time of getting them on all the medications that's needed. So some common medicines that we're using, lisinopril is probably one of the most common ones that is used along with enalapril. And some of the initial starting doses that you'll see is the 2.5 to 5 milligrams. But remember, our target dose when they studied lisinopril in particular was over 30 milligrams a day. So really want to try to get these patients to 20 to 40 milligrams. And although that can be very difficult, that's something that we should kind of continuously monitor and evaluate the patients to see, can we get them on the doses of medicine to try to give them the most benefit for these medications. For losartan is another common if we're out there on ARB. Again, it's at 50 to 150 milligrams a day to try to get them on. And with the ARNI medication with Entresto, this is probably one of the bigger hurdles that we've seen, because it can have a bigger effect on blood pressure that we've seen in our patients. And even though we start them on that 24 milligrams of it, ideally we want to try to get them to that 97 milligrams. And sometimes it's just tough to get there, but have that in mind. If they can tolerate it, we want to try to get them to that 97 milligram dose of that medicine. As far as our beta blockers, our toprol, it's 200 milligrams. That's our target. And I know, to be honest, I have very few patients actually hitting that target of getting on 200 milligrams and tolerating 200 milligrams of metoprolol, but we should work towards it to see if we can tolerate it. If it's Coreg, that 25 to 50 milligrams twice a day on some of these patients. With your MRA medications, getting them on spironolactone, we want to try to get them to 25 to 50 milligrams a day to try to get as much benefit from these medicines as possible. As far as your SGLT2 inhibitors, they're kind of just one dose, 10 milligrams. That's for Jardiance, Farxiga, and INPEFA is a 200 milligram dose. That's not listed on there. So work on getting these medications. These you don't have to really titrate as much, and they have a broader indication to start these medications. So it's something to look into. It's kind of the new kid on the block, and we're showing benefits with heart failure. As far as isosorbide and hydralazine, they do have these fixed dose combinations that we try to get them on. But again, this is a certain subset of populations, your Afro-American population that are New York Heart Class 3 or higher, or patients that can't tolerate your ACE, ARBs, or ARNIs that we're going to get them on these medications. Some other ones that we use in the stage C, the ivabranidine, not used as much. This is a medicine we try to use if patients are kind of on their maximally tolerated metoprolol. The heart rates are still above 75 beats per minute. Really no other conduction abnormalities on EKG. Kind of start this medication to kind of reduce the heart rate. So that's something to consider in these patient population. But again, not as many patients on that medicine. So again, patients that are coming in, when we try to add additional therapies, these class 3, you've kind of optimized them on this goal-directed medical therapy. They're still having some symptoms. If you have these patients that are kind of this class 2 or 3, they're still symptomatic. They're in a normal sinus rhythm. Their heart rate's above 70. You're on maximally tolerated beta blockers. Ivermectin is a medicine that we can consider. Other medicines, these 2Bs, again, not as much evidence for digoxin and some of these other medicines, these potassium binders, might have some benefit. It just might be some mild to maybe not causing any more harm. But again, if your patients are continuing to be symptomatic and you have no other options, it's medicines to consider. As far as ICD therapy and resynchronization therapy, if our patients, if they're 40 days post-MI, if they have ischemic heart disease, or if they're non-ischemic cardiomyopathy that have gone through goal-directed medical therapy, still symptomatic, and their EF is less than or equal to 35%. It's a class 1 indication for an ICD. So I should always be monitoring these patients, have follow-up at these time frames, evaluating patients' ejection fraction to see if they qualify for an ICD, because this helps reduce sudden cardiac death to reduce mortality in these patients. As far as revascularization, again, we're looking for things that can try to improve in causing heart failure. So if these patients have ischemic disease, it's suitable to take a look at the coronary anatomy to see if they can be surgically revascularized to improve symptoms and improve long-term mortality. So again, these are more additional therapies. Patients that have valvular heart disease with severe MR, it's not indicated right away just to fix the MR. You really want to optimize your goal-directed medical therapy before intervening on MR. We have a lot of cases where MR can improve with medical therapy, with improving heart function or arrhythmias, because sometimes in these patients, especially if they have a reduced ejection fraction, and if you fix their regurgitation, their heart function can get worse. So you got to be careful in this subset of population where if their ejection fraction is less than 35%, it's actually contraindicated to put them for surgical repair of the valve, because you can actually make things worse. So we really want to optimize medical therapy in our severe MR patients. But if we talk about coronary artery disease, it's feasible to take a look and see if we need to revascularize these patients to help improve their symptoms. Again, with valvular heart disease, if it's aortic disease, aortic stenosis, regurgitation, we can look at trying to help with repairing the valves. But someone that has severe secondary MR with reduced ejection fraction, you really want to optimize goal-directed medical therapy first in these patients. Now, in this gray area, so we talked about that's our patients with this severely reduced ejection fraction, but now we have this gray area now that we're calling heart failure with this mildly reduced ejection fraction. So really, in these patient populations, the 2A indication for these is putting on the SGLT2 inhibitors. These medicines with Jardiance, Farxiga, and Pefa have actually surpassed the recommendation for your Entrestos, your ACE inhibitors, your ARBs in starting medications. So your first line should be putting them on this SGLT2 inhibitors if they have this mildly reduced ejection fraction. So that's a 41% to 49% EF. And then looking at the ACE, ARBs, or Entresto medications. Diuretics, again, are class 1 indication and are as needed. Again, diuretics don't improve morbidity or mortality, but they help with symptoms of the patient. But what can improve overall mortality is the SGLT2 inhibitors. It has a 2A indication. And then beneath that, and our mildly reduced ejection fraction patients, is when we start having our ACE inhibitors, our ARBs, our ARNIs, our MRAs, and then the beta blocker therapy. So again, diuretics first in these patient population and with the SGLT2 inhibitors, and see how they do. Now, once we treat the patients, if they fall into this category of an improved ejection fraction, so they were less than 40%, now they're greater than 40% with improved ejection fraction, we still want to keep them on their medications. Even though they become asymptomatic, heart function improved, we want to continue with goal-directed medical therapy to prevent relapse of heart failure. I know in the past, a lot of times we were just stopping therapies on patients once we saw an improvement in their ejection fraction, but really we should try to optimize and continue on the medicines that they can tolerate as long as possible. Now, patients with preserved ejection fraction, we're really going to start looking class 1 indication for these patients of looking at what other risk factors they have to treat. So if they have hypertension, we really need to kind of target blood pressure and focus on medication to help improve blood pressure. Also on these medications, if they have preserved ejection fraction, if they have other indications to help, it's a 2 indication to start these patients on the SGLT2 inhibitors. So again, this is another time where these SGLT2s have kind of moved up the rankings in our recommendations to help patients with heart failure across the board. Also, we got to look at other indications like AFib, patients with AFib. We should be managing these AFib patients to try to improve the overall symptoms. So again, patients with preserved ejection fraction, class 1 indication, diuretics as needed to help out with symptoms. These SGLT2 inhibitors, they can help improve morbidity and mortality. And then next in line is our ARNI medications with the MRAs and ARBs. Things that we're not going to have today is stage D. So once someone gets to stage D, we really got to get these patients to our tertiary centers, our advanced heart failure specialist. So if they have an EF of less than 25%, or if their symptoms are progressing despite maximizing their goal-directed medical therapy, we got to get them to advanced therapies to see what else we can do for these patients. So some top take-home messages for you guys today. Guideline-directed medical therapy is what we're kind of shooting for heart failure. So if they have reduced ejection fraction, today it includes 4 medication classes. And kind of the new kid on the block is that SGLT2 inhibitors. Then you have your beta blockers. And remember, with the beta blockers, it's not any beta blocker. We're looking at your Zebeda, your Coreg, your Toprol, your MRAs we're looking at, along with your ARNI medication, your Entresto. These are kind of our first line treatments that we want with patients with reduced ejection fraction. The SGLT2 inhibitors, again, they have 2A recommendations with patients with mildly reduced ejection fractions. And that's higher than our previous medicines with our Entresto, our ACE inhibitors, ARBs, MRAs, and beta blockers. Patients with preserved ejection fraction, again, it's a 2A indication for this SGLT2 inhibitors and 2Bs for the MRAs and Entresto. Now, you also have to continue with prior recommendations, and these patients with preserved ejection fractions, we got to continue to treat high blood pressure, atrial fibrillation, and use these medicines and try to avoid routine use of nitrates and those phosphodiesterase 5 inhibitors, which have really shown no benefit in our heart failure patients. Once patient has improved ejection fraction, so they had a low ejection fraction, less than 40%, now it's greater than 40%, we really should continue therapy for these patients and not take away therapy on these patients. Patients with advanced heart failure, we got to get them to our tertiary specialists, our advanced heart failure specialists, get them evaluated for assist devices, more IV therapies, along with transplant as soon as possible. With our newer stages, our stage A, our stage B, it kind of identifies our patients at risk. So it's important now to really take home and see what patients are at risk and emphasize primary prevention before we get to that stage C. So with that, guys, I want to thank you guys for taking the time to listen to me, and I'll answer any questions that you guys might have.
Thank you very much, Dr. Forchello. We really appreciate it. If y'all do have any questions, go ahead and put them in the chat. I know that was a lot of information. I actually have a question.
Yeah.
Have you seen any heart failure improvements with the weight loss Ozempics and stuff that have come out recently, and people that have taken those? Does it affect heart failure symptoms? Does it improve anything?
We don't have enough data to say we have anecdotal data either way, where patients getting worse or better. But to be honest, I don't have any long-term data with these medicines with improvement of heart failure specific. And especially with patients with reduced ejection fraction, we don't have enough data to say if they're beneficial to put them in the guidelines yet, if they're beneficial.
All right, I appreciate that. If y'all have any other questions, please go ahead and enter them in the chat. If you have joined today's webinar on your phone, be sure you email Lisa Starnes at lisa@medication education.org, or I'm sorry, .com, and she will take care of your CEUs. We had a glitch in the sign-up process, as about half of you are aware. So please go ahead and shoot her an email. She'll take care of your CE. Include your phone number in there so she can get back to you. And she's included her email in the chat as well. And I don't see any questions. We're here at the top of the hour at 1 o'clock. If you guys do have any questions, even afterwards, you can email those to Lisa as well, and I'll get them to Dr. Forcella, and we'll get back to you. Thank you guys very, very much. We really appreciate it.
All right. Thank you, guys. Have a great day.
Great afternoon, Dr. Forcella. Thank you very much.
You too.
All right. See you, everybody. Bye.